Good morning, everyone. It's brilliant to see so many people in attendance this morning, and people are still coming in. I can see so we may just kick off. So my name is Fiona Kyle. I'm the CEO of Mental Health Reform, and you're all very welcome to this morning's pre-budget submission 2020-15 launch. Thank you for joining us. Thank you for your interest in mental health. So just before we begin, if we could go to the next slide, I just want to make people aware that sometimes when we talk about mental health, we very much recognise that conversations can be triggering or upsetting to some people, but just to make you aware that support is there and it is available. So there are a number of links to support lines there, so you can text hello to 50808 to start a conversation. It's anonymous and free, and then on our website there is a list of supports that our member organisations do, as well as the HSE mental health page, which gives you a full list of range of supports. So thank you so much for joining us here today for I suppose the final pre-budget submission for this government at least. And we know that in Ireland, I think we often say it is mental health reform, that the topic of mental health has often been shrouded in silence, and it hasn't come with the urgency it deserves. And we try at Mental Health Reform with our member organisations, with the amazing, brilliant activists with lived and living experience, to really shine a spotlight on the importance of really unequivocally shining a spotlight that mental health matters, that every individual grappling with mental health difficulties, their family, friends and supporters, are deserving of support, a human rights, effective based care and support. So this year we will continue our theme of I Am a Reason. And I suppose this really speaks to how, behind the numbers that we will talk about today, and, it's budget, so we're asking for monetary numbers, but behind every number and every cent and every euro, there's a person, there's individuals impacted by the services that they are or may not be receiving. I suppose, I'm struck over recent weeks and months, we've heard of families who are struggling to get support for their young people, of the mother who's been kind of bravely speaking out in terms of their own child who has autism and is unable to get supports and services, of the older person living in the country who doesn't have access to supports, or the young mother perhaps down the country struggling with postpartum depression. These are individuals, they're not statistics. They're our friends, they're our families, they're us, they're our community. And each one is a reason for change, a reason for investment, and a reason to make mental health a priority. So to the government, with Mental Health Reform, with our members, we're really urging you today to see how many reasons there are to invest in mental health. For decades, many of these individuals have perhaps not been vocal about their experience, because mental health has and continues to be surrounded by stigma. But I think that this is a moment for this government to really separate mental health, to show the real parity of esteem. And by doing that, by really putting your stamp on on your cycle in government, by really giving mental health the true investment that it needs in the upcoming budget. By prioritising mental health now, you can ensure that your time in office is remembered for the positive change it's brought about to the lives of these countless Irish citizens. So today's event is going to shine a spotlight on different perspectives, those who are tirelessly working within the system, who are supporting services, and individuals with lived experience of the system. So I'm going to hand over now to my colleague, Suzanne Weedle, who is our Policy and Advocacy Coordinator, and she's going to talk us through the numbers. So what we're asking for today is very clear additional 120 million investment in our mental health services in the upcoming budget. So Suzanne, I'm going to hand over to you to talk us through what that figure means and what difference it's going to make. So thanks so much, Susanna.
Great. Thanks so much, Fiona. Hello, everybody, and welcome. My name is Susanna. I'm the Policy and Advocacy Coordinator here at Mental Health Reform, and I'm going to give you a whistle-stop tour of our pre-budget submission. So firstly, as Fiona said, we're calling for an investment of an additional €120 million in budget 2025 to mental health. We know that under Sláintecare, the target is to reach an investment of 10% of the health budget being allocated to mental health. And unfortunately, while we have seen a very welcome additional investment in mental health each year, the mental health budget has stagnated at between 5 and 6% of the health budget over the lifetime of the current government. And if the government were to reach this target of investing 10% of the health budget into mental health, this would require an investment of at least an additional €1 billion in budget 2025. So an additional 120 million is quite a modest and pragmatic ask within this context. On our next slide, I'm going to take you through some of the 4 key areas that we highlight in the submission. So we do break down the costings a bit more within the pre-budget submission, but for now, I'm just going to discuss the overarching themes. So the first is investment in communities, investment into the services provided by Mental Health Reform's member organisations. And we're very lucky to be joined here today for our panel discussion later by 2 of Mental Health Reform's member organisations, Alone and ADHD Ireland. The second area we're going to focus on is around sharing the vision, our national mental health policy. And as we face into elections within the coming year, it's an important time to reflect on the fact that sharing the vision is our national mental health policy until 2030. This means it is a policy that is important to every political party, regardless of the election outcome. 2024 is the final year of the current implementation plan of sharing the vision. It's a time to reflect on what has been achieved so far and what we'd like to see included in the next implementation plan. The population of the Republic of Ireland is set to increase by 6% between now and 2030 over the timeframe of sharing the vision. So even to maintain the current levels of service provision, the funding will need to significantly increase to serve our growing population. While we don't have exact data on mental health prevalence in Ireland, there is research that indicates that Ireland's prevalence rates of mental health difficulties are relatively high in comparison to international estimates. We also know that Ireland has the highest difficulty in accessing mental health services in Europe. One aspect of sharing the vision that Mental Health Reform has highlighted in our pre-budget submissions is the national clinical programmes in mental health. And we're very fortunate to have Dr. Michelle Clifford, who is the clinical lead on the National Clinical Programme for Eating Disorders, joining us for our panel discussion later. The third area we focus on is youth mental health. The need for increased funding in youth mental health is evident. We've seen several reports highlight this necessity over the last few years. We've had the Maskey report into South Kerry CAMHS in 2022. In 2023, we had the concluding observations from the Committee on the UN Convention on the Rights of the Child. We had the Mental Health Commission's report on CAMHS and the Ombudsman for Children's report, A Piece of My Mind. More recently, Families for Reform of CAMHS published their report, Experiences of CAMHS, a Family Perspective, in 2024. And what all these reports demonstrate is the extent of the need for investment into youth mental health services. We've also seen some positive developments in youth mental health. We've seen the establishment of the HSE National Office for Child and Youth Mental Health, which is an extremely welcome development, as well as the single point of access triage system that is currently being piloted in 2 CHOs. However, we know that there are insufficient services to meet the demand for young people, particularly in the area of early intervention and prevention. And so investing in the voluntary community sector mental health services who provide this for young people is vital for Budget 2025. Finally, one of the very founding reasons for mental health reform was to advocate for a more human rights compliant mental health legislation and the reform of the Mental Health Act 2001. We're very pleased to see that Minister Butler has introduced the bill to reform the Mental Health Act to Cabinet, and we're eagerly awaiting the publication of the reform bill. This is a once-in-a-generation opportunity to make our mental health legislation more person-centred and human rights compliant. But this type of reform requires financial resourcing to ensure its success. The time to begin allocating resources to this reform is now. There are many aspects that will take time to scale up. For example, the expansion of the authorised officer role, the expansion of the regulatory remit of the Mental Health Commission, and Mental Health Reform would also like to see advocacy placed on a statutory footing within the legislation, as is the case in many other jurisdictions. And so we need to resource mental health advocacy services, authorised officer recruitment, and the Mental Health Commission's regulatory services in Budget 2025 if we are serious about legislative reform being realised and practised at the earliest possible juncture. So on the next slide, I'd just like to hone in on two particular aspects of the pre-budget submission. The first is around the voluntary and community mental health sector. And I think this quote here from a respondent to our pre-budget survey really captures the essence of our message here today. It says, let's start helping people upriver rather than only when they are really struggling. And I think it's fair to say our member organisations are doing just that. They're helping people upriver. I think it's important that we take a moment to reflect on the sheer volume of activity that is occurring within the voluntary community mental health sector. So this table here is from one of our projects called Brave New Connections, and this piece was published in 2022. And it estimated that on an annual basis, the sector provides over 870,000 helpline or crisis contacts, over 220,000 counselling and psychotherapy sessions, and reaches over 130,000 people with psychoeducation and self-help supports, as well as over 90,000 people with peer support, advocacy, recovery, social inclusion, or other programs. We know that the sector is becoming squeezed by increasing demand on service provision without the corresponding funding increases. And some of our member organisations have even recorded the highest ever number of mental health referrals in the history of their service provision last year. The evidence of this increased demand can be seen in our pre-budget submission, where we have analysed the trends in demand based on the activity noted in the annual reports of some of our member organisations. On the next slide, the second piece I'd like to highlight is about the shortfall in funding that has been seen in the rollout of some of the implementation milestones for sharing the vision, particularly among the 6 national clinical programmes for mental health. So as you can see in the table on the left, we have the name of the 6 national clinical programmes for mental health. The second column shows us what was meant to be achieved by the end of 2024. The third column shows us where we are currently, and the final column shows us the shortfall. Now, I will say that there has been funding announced for a 12th team for eating disorders national clinical programme, but we know that it's not yet operational. So we've kept the number to 11 there, but Dr. Michelle might be able to speak to that a bit later. As you can see, we are significantly behind targets for all of these teams. While of course recruitment difficulties are a factor, the chronic underfunding of the rollout of the national clinical programmes is a significant barrier, with many of the progress reports on sharing the vision making it very clear that underfunding is impeding progress. So on the next slide, I'm just going to take you through a few other pieces. So we all know the human cost of not investing in mental health, and I think Fiona has made that very clear in her opening statements. And at Mental Health Reform, it is the human rights-based imperative that to invest that is the most important to us and to our member organisations. But there's also a very significant economic cost to this lack of investment. So the OECD has estimated that half of the population will experience mental health difficulty at least once in their lifetime. And the economic costs of poor mental health amount to more than 4% of GDP annually. In 2018, the then Health Minister Simon Harris stated that the poor mental health costs the Irish state €8.2 billion a year. And a 2019 study from the Global Burden of Disease showed that for those aged 5 to 24 years old, mental health difficulties are responsible for more than 20% of the statistic they use as years lived with a disability. So this is higher than the impact of any medical condition for this age category. There's much more extensive research in the UK context on the impact of inadequate mental health funding on the economy. However, Mental Health Reform are partnering with the London School of Economics and 5 of our member organisations on a very exciting piece of research that will be published later this year around the return on investment for certain early intervention mental health programmes for young people. And we can already see from preliminary findings that there's a clear return on investment for these programmes. So on the next slide, in summary, I would say that right now, there are high rates of mental health difficulties in Ireland. There are demographic changes in mental health prevalence. There are low rates of investment in mental health. There are reforms to mental health legislation on the horizon, and there are increased demands on the voluntary and community mental health sector. Right now is the time for investment. We all have reasons to invest in mental health. We often talk about lived experience of mental health difficulties, but we're often told that a more accurate term is probably living experience. And I think we all have different living experiences when it comes to mental health. It may be our own experiences or our experience as a friend, as a family member, as a neighbour, as a service provider, or as a political representative listening to the concerns of their constituents. Our reasons for investment in mental health are manifold. The human cost of a lack of investment is enormous. Not only this, but investing in mental health, especially early intervention and prevention services, is beneficial for our economy as a whole. And so our message to everyone today is that investing in mental health is an invest to save model. Not only does it have the potential to save money, it has the potential to save lives. And now I'm delighted to hand you over to my colleague, Ber Grogan, who is going to chair a panel discussion, and I've no doubt their discussion will show us many more reasons why we should invest in mental health.
Thank you so much, Susanna. It's just, I know I'm familiar with the content of the pre-budget submission, but it's just phenomenal every time we see it. And I really hope you know, yourself and Fiona have made the point so well about that it's about the human cost and the human investment, but we really are trying to use kind of government terms around, you know, it's prudent to invest in mental health. It's not a cost. There will be economic benefits. So it doesn't make sense to not invest in mental health. So I'm delighted to be joined by our panel now, and I'm going to ask each of them as I'm introducing you to unmute yourself and turn back on your camera. So we have Nicola Koss, who is the National Service Development Manager of ADHD Ireland. So Nicola has spent over 20 years in business, disability and youth sectors and has pledged the last 7 years of her career to supporting people with ADHD as the National Service Development Manager with ADHD Ireland. We have Sean Moynihan, the CEO of Alone, who's worked in the NGO sector for over 25 years, has been involved in multiple national oversight groups and has played a role in influencing social and health policies for older people on housing, loneliness, aging at home, in order to meet the needs of the aging population. And then we also have Dr. Michelle Clifford, who is, as Susanna mentioned, she's the HSE National Clinical Lead for Eating Disorders. So Michelle leads the implementation of the HSE model of care, is a consultant child and adolescent psychiatrist, and is leading a multidisciplinary community-based eating disorder service in Dublin. So I have a couple of questions for each. And then we'll then after that I'll be speaking to Rebecca. Sorry, I'm just changing my view to gallery speaker view so I can see all of our panelists. So Nicola, I'm going to come to you first. So as we know, many organisations in the community and voluntary sector have undergone significant changes since the pandemic, including developing remote services and then the increased demand for support, which Susanna spoke about. Can you give us a bit of insight into how the pandemic impacted ADHD Ireland and how you as an organisation responded to that and to the needs of the public?
Yeah, the pandemic was a big stopfall for a lot of people, and thankfully for ourselves and our ADHDers, we took to Zoom and to online events very, very easily. And we have 230,000 people out there, 5% of the population have ADHD, and we're kind of a victim of our own success. So the more information that's out there, the more awareness that's out there, the more demand is coming on our services. We only have about 10 staff. Most of us are part-time. We're working full-time hours just to get the job done. Like many other charity organisations, we're taking the brunt of when there's not enough early intervention, there's not enough funding, there's 2-year waiting list. Just to give you an idea, there's 124 kids are waiting nearly over a year for a diagnosis of ADHD in the Midlands. That's across the country. So there's 764 waiting to be seen nationally. So we've a lot of kids waiting a year to 2 years, trying to work through school, trying to work through their anxiety, getting in trouble in school, being excluded socially for their behaviours because they don't understand and the teacher doesn't understand it. So our job and our mission mainly is to improve the lives of people with ADHD. What we're trying to do is get as many events out there. So when we went online, it all just blew up on us. We went from doing about 150 events to nearly 500 there back last year. And we just cannot keep up with the demand. We're working for parents, we're putting expert webinars out there for employers, for corporate sector, for teachers. And something like 34,000 teachers have gone through our schools programme. The need is there, the want for understanding is there. But like other charities, because the money isn't there in the system, we're the backlash, and we're the voluntary organisation that other people have to pick up on. And where do they go when they can't get, they're told they've a waiting list, 2 years, GP says, right, go to ADHD Ireland, they'll support you. And that's what we're there for. And we're delighted to be here, but unfortunately, because we're doing the work of nearly 20 people and only 10 of us here, we could do with 30 people to do the job we're doing. And that's where investment is needed. Money is really well spent in the charity sector. They get a lot back for the money. And 1.8 billion at the moment for interventions. If they only put the money into early intervention, it would make a massive difference to our ADHD set as well as many others.
There's such brilliant points, Nicola, and I know in our pre-budget submission, Susanna has the information about the HSE puts about 1% of their funding into early intervention and prevention measures, even though we know that there's an economic return of 2 or 3 or 4 times more than that. And I think it's really interesting when we're talking about the early intervention and prevention side of things, but ADHD Ireland are actually getting referrals at crisis point because the early intervention and prevention pieces weren't there, and then it's kind of you're trying to fill in the gaps and the waiting lists. Sean, I'm going to come to you next, just about, obviously I'm sure a lot of people are very aware of the incredible work done by Alone, and I'm struck as well by the size of ADHD Ireland, and you know, obviously Alone have been around for a while, and are very well known as well. But I think sometimes when people think of the charity sector, they think every group is kind of the same size, or you know, as the same type of work that they're doing. But could you just give us a quick overview of the type of services that you're providing in Alone?
Brilliant. So listen, great to be here today. Great presentation to start off, and great pre-budget. So congratulations to everybody. I suppose what we do is support older people to age at home. We all know we've an aging demographic, and ultimately, like ADHD Ireland, we meet the emerging needs that come. Last year, we worked with around 33,000 older people. Ironically, Cork and Kerry were probably our highest levels of needed support. And what we do is we have a network of around 220 staff and around 5,000 volunteers. And what we do is we create support plans for the older people. Now, some days that's housing, some days that's physical health, some days that's mental health. And for us, and more of this later, is more and more there's around loneliness, mental health, and need. And again, I suppose in some ways we're bridging the gap where there may not be the services for older people. So what we do is create a support plan to empower the older person to age at home, no matter what the issue is. And then we leverage what's in the community for them. And then we have volunteers who visit, who combat isolation and loneliness, provide practical support, and link people back into social activity in the community. We're here 7 days a week, 12 hours a day. There's a support line, so people ring us, and our referrals are third from acute, third from primary care, and third from older people, friends or families themselves. It's not for today, but we're also an approved housing body, and we provide ultimately is housing to homeless older people, a lot of which will have mental health issues or addiction issues. And as well as that, we run a thing called Community Impact Network, and there's around 154 members where we share training, share resources, share knowledge, to ultimately trying to multiply what we do to meet what is a huge shift in the demographic and a huge shift in need in the community.
Brilliant, thanks. And we're going to come back to the demographic piece then, and my next question for you, but just to bring in Michelle now. So Susanna touched on the national clinical programs for mental health, but again, it would be really useful if you could just give our audience a sense of the services provided by yourselves in the national clinical program for eating disorders.
Morning, Byrne. Thank you so much for having me this morning to talk about eating disorders. So it might be helpful just to give an overview of the National Clinical Programme for Eating Disorders. And what we did was in 2018, we published the HSE's plan in terms of how eating disorder services should be developed in the Republic of Ireland. And since then, we've been working really hard to deliver that plan, and that plan is called our model of care. And what we focused on is the delivery of the outpatient, multidisciplinary, community specialist eating disorder teams across the country. And the recommendations are that they're delivered in all areas across the country and across all age ranges. So we prioritise both adult eating disorder teams and child and adolescent eating disorder teams, because equity of access and equity of care is an important core value for the clinical program, and then that network of teams will work really closely in the community with other healthcare settings that also look after people with eating disorders. And so again, a really core value is patient safety and integrated care. So we've developed care pathways across acute hospitals, pediatric hospitals, adult hospitals, with our colleagues working in inpatient settings, with GPs, and with our other colleagues working in other mental health community teams. Training and education is really important for the staff, because we know people with eating disorders want to be seen and want to be treated by staff that are experienced in eating disorders. So really developing that skilled workforce is important, and that also requires funding. We also do gather our annual data. So every year we publish on our website the number of referrals and the number of people treated and those that access treatment, and that's freely available on the HSE website as well. And then we work very closely with Bodywise. So Bodywise are the national support organisation for eating disorders. They do tremendous work, and they deliver their support services, which is really aligned with the treatments that we deliver in the community eating disorder teams. And we get really great feedback from families and carers that attend the Bodywise services. And we also have a self-care app that we have developed for anybody that's worried if they have an eating disorder or they're supporting somebody with an eating disorder. I can give you an update on where we are with the programme, but that might be for another question. But that's just giving an overview in terms of, so we're clinical services, about training, about education, it's about evaluating what we're doing, and it's really about improving the quality of care for people with eating disorders in Ireland. And just to say, prior to 2018, we had no community eating disorder teams for people with eating disorders in the HSE. So there's been lots of progress done, but lots to do. And so definitely more investment and more funding definitely required.
And that's such a good point, Michelle. And I think it's why at Mental Health Reform, we focus quite a lot on sharing the vision and the implementation plans and the national clinical programs, because they are doing great work around the country, but we need to see the goals being met, as part of the implementation plan. And you gave a really great example of how the integration of services with the community and voluntary sector, Bodywise are members of ours as well, and how when we're all working together, there's going to be better outcomes for people. You might just touch on Susanna's point there about, so she's left it as 11, but there was funding announced for a 12th team, was it?
So we've got 11 teams, we've 6 adult teams and 5 CAMS teams, or teams for children and adolescents, and they're all operational. Now they're at different stages depending on when the teams would have started, and also the resources have been allocated. They're not all funded according to the model of care, just to say. So certainly the funding needs to be topped up for those teams as well. And the 12th team was announced in May, and that's for an adult eating disorder team in Dublin. So that's not operational yet, and we're just still awaiting the final announcement for that funding so we can start the recruitment. But just to say, these areas, once they get the funding, they're ready to go. They're ready to go. They're looking for premises. They're actively already seeking out recruitment. So once we get the money, we're good to go.
Brilliant. And that's why announcements on budget day are so important, and to have clarity in the budget day announcements. Just to say, I see some questions coming in through the Q&A function, so people do feel free to put some questions in there, and either Susanna or someone in the background will be answering. And actually someone put a point, and it's really good. I'm going to come back to you, Nicola, about early intervention in ADHD, and it made me reflect quick multitasking around the use of the language early intervention and prevention. And I think maybe prevention is the wrong word to use sometimes. Maybe it's around early intervention and access to supports or awareness, and people living with mental health difficulties, in whatever form that they take, and living their recovery. But in relation to ADHD, what difference does early intervention make to the lives of children and young people?
Oh, it can completely change their life outcomes. If earlier intervention happens at a stage where the child needs it. So if the child is 6 or 8 in school, having trouble focusing, anxious in school, and maybe having behavioural issues because they're not understood, they're not emotionally able to explain and name and tame their emotions, essentially, that can have serious difficulties in the classroom. The teacher, can take a dislike to him, or they can misread his behaviors as deliberate and intentional and malicious, when in fact a lot of the time it's, I need to go to the toilet, I can't focus, I need a movement break, and I don't know how to explain this to you. And ADHD, attention deficit hyperactivity disorder, is not a lot of the time about the deficit of attention. It's about too much attention on the things they shouldn't be looking at, and not enough attention on the stuff that, if it interests me, I love my subject, I'll do really well, and I'll go I could be a geography teacher if I love geography. If I hate it, I hate it, and I will hate it from the day I walk into school. But unfortunately, for kids who are waiting 2 years for that diagnosis, parents are sitting there, what do we do with the kids? The schools have no idea what to do. They don't know how to put accommodations into place. And without that support, kids with ADHD, particularly with the traits, whether they have a diagnosis or not, are having negative comments constantly. And research has shown that they can have up to 20,000 negative comments before the age of 12. So if they're not diagnosed and they're in the system and they're sitting waiting on this diagnosis, that magic bullet is not going to come very fast. And things are changing with them academically, socially, and emotionally. And they're scars that are going to carry with them for the rest of their lives. So if they don't get the diagnosis, don't get the support, they're actually very, very susceptible to addiction, self-medicating, eating disorders, emotional dysregulation. Then that later on in life will turn into not being able to keep relationships, marriage breakups, because the partner doesn't understand why they're not paying the bills, why they're looking like they're lazy, why they're not thinking to pick up the brush and clean the floor. Financially, they can get into trouble. They can have a lot of accidents because they're totally impulsive. But this can all have been prevented way, way back, because ADHD is one of the most manageable and treatable conditions if done effectively and early.
And I think the power of what you've just said is so stark. And I think we've seen from groups like Family for Reform of CAMHS and others that have spoken about kind of the gap in access to services if children have a diagnosis of ADHD and then been turned away from CAMHS. And we know that that's something that Dr. Mandy Burke and Doan and Kelly in the National Office are looking at. But that has been the experience of many people and children over the years. Sean, to come to the other end then of when we're talking about sharing the vision of as a life cycle mental health policy, you touched on about demographic changes, and it's also something we hear the government talk a lot about, so usually it's referring to Ireland's ageing population and the implications of that for our economy. So just around the mental health aspects of that demographic change, are you seeing any particular trends around mental health in alone with your services? Like, is there an increase in demand, or are you seeing that mental health is maybe more of a focus? And you're on mute, so I'm going to unmute you. We're also polite muting ourselves when we're offline. There you go.
Anyway, listen, I suppose, look, for us, right, just so people know, the majority of people we work with are over 70. Okay. On top of that is we always talk about an aging demographic, and then we get killed with the stats of it and we can't visualize it. I think what we're saying is now there's around 800,000 people over 65. One in around every 7 person is over 65. So if you imagine, for the health service, for the transport system, for every part of government, including mental health services, so to speak, if you want to put it this way, the client or the customer is changing. Do you know what I mean? So the needs are changing. I think for us, what we're seeing is unfortunately, Ireland is the loneliest country in Europe, according to European research, right? And for us, we are overwhelmed with the amount of people who are lonely, right? Of those assessed, we produce a quarterly data report and assessment report, linked to the Enhanced Community Care Programme. It's on our website if anybody wants to look up data, but gives you data on mental health, physical health, transport, finance, everything affecting older people. But of those who come to us in the first quarter of this year, around 26% of people are showing evidence of mental health issues. And of them, around 50% are not linked into any services. The TILDA data is actually higher. Of those, TILDA data shows that of older people who are showing evidence of depression and anxiety, 70 and 80% are not linked into services. And I suppose there might be other researchers and people who could better understand than me ultimately why that is. Our own belief is probably because older people grew up where the conversations about your mental health and your mental well-being really probably weren't held. Do you know what I mean? So from that point of view is there may be a barrier of language, even down to loneliness. It's a big thing to say I'm lonely. you know, and the predicator that has to poor mental health, the predicator that has to poor physical health. And people may not have the ability to distinguish that, because through their own education, through their own adults, that was not a conversation that was really held. So for us, we see that there's a huge, undiagnosed, unsupported group there, ultimately, probably because the system has grown out of younger people a bit more than it's grown out of older people. But ultimately, it's because older people are so much part of the population, ultimately is we need to keep that focus. And that's why we were delighted to be asked today, because it keeps us in the conversation. Whereas, as I said, we're not experts in mental health. The reality is 26% of those who are assessed this quarter are actually presenting with mental health or evidence of mental health needs.
Yeah, and thanks so much for that, Sean. And I think in our pre-budget submission, we've also included, you know, not just kind of the figures of the CAMHS outpatient appointments, but also the general adult, and then also the psychiatry in later life, you know, because we are really trying to make sure the conversation has been had about services for everyone. Nicola, I'm just going to come back to you really quickly, because I know you have to run off because you're doing some media as well to try and spread a lot of awareness today about the pre-budget launch, and then I'll come back to Michelle. So just really quickly, Nicola, in like a sentence or two, what impact would multi-annual or increased funding have on your organisation and the people you support?
Huge. At the end of the day, thousands of people are coming into our service every year. Last year alone, we had 2,500 adults needing support now. They were not getting it from the services. They came to us. We had nearly just 2,000 parents ringing in about their kids. They need help now. They are not getting that support now. Just mental health is not about numbers. But if you want to take numbers, the general population, suicidal ideation is around 10% of the population. But with ADHD, it's twice that. So it is seriously a major issue. And we can find when we had research with National Council of Suicide Prevention, numbers matter. Currency doesn't matter. You know, buying bigger art installations, retarring a road for the third time in 6 years, that doesn't matter. People matter. Mental health matters. Children, parents, older people. I really resonate, Sean, with your demographic, because we can see a lot of our older adults are going to be those lonely adults. They're broken marriages, kids with no friends. We see this exclusion already. We see they're going to be that scenario. But if 20% of adults with a diagnosis, with all the support they can possibly have, 20% have actually said in a survey last year from National Council Office of Suicide Prevention that they've attempted suicide. 1 out of 5. That is huge numbers. That is serious. Mental health is not about numbers. Mental health is about people. It's about lives, and it's about real lives. And if those supports do not come into play and that immediate action isn't there, people are not going to be here. And that's the reality, and the very stark reality of it. And I'll leave you with that.
Thank you so much, Nicola.
Thank you so much for having us, guys.
No, it's been so important, and it's just reminded me as well to kind of touch on, obviously, in case people don't know, that there are priority groups under Sharing the Vision. So the likes of ethnic minorities and people experiencing homelessness or addiction, people in the LGBTQI plus community, you know, so within our mental health policy and the work that we do, traveller community, you know, we know there are certain groups of people who are more susceptible to mental health difficulties, or to have a number of discriminatory barriers to access and services. So just to say, that is something that we're very aware of in mental health reform. Michelle, I'm going to come to you really quickly. Sorry, our panel time has flown in, and then I've to come back to Rebecca. But just for a last question for you, Michelle, is around the demographic change piece as well. Are you seeing any differences in the referrals? Are referrals increasing, or the types of presentations that you're seeing with eating disorders? Have there been any kind of noticeable changes with that?
Thanks, Bro. Yeah, I mean, in short, certainly since the model of care was published in 2018, the demand has increased. So you would expect when you start to develop new services with increased awareness and increased pickup of cases that you're actually going to see an increased demand for services. Along with all other mental health conditions, absolutely, we saw a big rise in the pandemic. So the eating disorders peaked around mid-2021, and there was a 250% increase in referrals into the eating disorder teams in that year. So it was huge. In a week, we were getting a month's worth of referrals, and I was working on the ground in one of those teams. It was really overwhelming. So you can imagine what it was like for families and people with eating disorders. So that then really impacted on our access times as well. Now, it has started to decrease, thankfully, and teams are kind of catching up on those waiting lists, but the rates of referrals are still about 150% higher than they would have been in 2019. It's a really young age group. About 2/3 of referrals are for under 18s. In the adult age group, it's between 18 and 24. So eating disorders really impact on a young section of the population. And we are probably seeing an increase in the younger age group in 10 to 14s. So it's not unusual now to have children with eating disorders referred from primary school. The most common eating disorder we see is anorexia nervosa. That's the one we see most commonly clinically. It's the least common eating disorder, but it's the one that's associated with the highest mortality rate of all mental health disorders. And that's why it's so important in terms of with our integrated care that I mentioned earlier, and also early intervention. So I think what we are seeing is that we're seeing an increase in referrals, and the COVID pandemic did impact on the access times. We've worked really hard and continuing to work hard to make sure that people are seen early, within 4 weeks of referral for assessment, and then start treatment. We're really trying to avoid treatment waiting lists. And also, and in terms of the demographic, we're probably seeing a huge comorbidity actually with autism spectrum disorders and neurodiversity. So that is something that's really important for us to recognise, and that also brings up the need for training and for education in terms of how we our teams develop that experience in managing these cases as well within the eating disorder teams. But yeah, the demand is definitely higher than we would have expected, and the population is growing, so we obviously do need to review our model of care and just to see where the demand is going to lie in the years going forward as we continue to implement and roll out the teams and the model of care.
Brilliant. Thanks so much, Michelle. And I think it can be so frustrating for us in mental health reform and our members when, we hear kind of media clips of, a historic level of funding in mental health and things like that, without any recognition of the fact that the demographics are growing, the need is growing, and obviously there's a change in demographics, and there's a cost of services existing and all of that kind of stuff. So because I'm running out. I could talk to you all morning, but I'm going to bring on Rebecca, who's also has so many insights to bring to us. So Michelle and Sean, I'll just say thanks, and if you want to mute and turn your camera off there again, and Rebecca, you can unmute yourself. And yeah, so Rebecca is a member of our Grassroots Forum, which is a group of people with lived experience who help inform our policy and advocacy work. She's also a blogger for Spun Out and has written about her experience of accessing mental health services to inform and help other young people. And here she is in our lovely t-shirt of our hashtag I Am a Reason campaign. So Rebecca, thank you so much for joining us this morning, and apologies for the tech check stress as well. That's why we do these checks, but thank you so much. We're delighted to have you here. So I'm just wondering, are you happy to tell us a little bit about your experience of being a member of the Grassroots Forum and how you use your experience in advocating for change, and about how, so you have significant experience in navigating the services. How did you find that? What did you learn from it? Did you encounter challenges, just as much as you're comfortable talking to us about?
Yeah, so I'm really grateful to be part of the Grassroots Forum, and I kind of came to that from Spun Out, and Spun Out is kind of what originally allowed me to share my lived experience, and I like being able to use it for good, because obviously experience with mental health is tough, so it's great to be able to use it to help people. Youth to adult services wasn't straightforward at all, so it was kind of like being thrown in the deep end. Now I know I'm 26 now, so things thankfully are changing, but very slowly. But for me, the challenges were, it was really difficult to find youth services, especially public services. And then it was only when I turned 18 that it was easier to access services. But again, like I said, with youth services, it was public services, adult services. I'm privileged. I have health insurance. So I'm so grateful to have been able to do that. But that is a major challenge for other young people. They don't have access to health insurance, or, well, a challenge to a lot of people, not just young people. But I think for me, it was a big challenge, the youth to adult service, the transition. But I was lucky because I have health insurance. So that's what made it a bit easier for me, but it is still challenging for other people.
Yeah, and it's such a good point that we hear all the time about kind of the two-tier system in mental health services, that if you are lucky and privileged enough to have access to funds, you know, you can pay for private therapies and treatments, but otherwise you're going to be on waiting lists. Will you tell us a little bit more about your collaboration with Spun Out, who are also one of our members? So what is it that you're doing, and how has that helped you? I know you said you're using your experience for good, which is amazing. Also not your responsibility, but we're so glad that you are doing that. So just tell us a little bit about your collaboration with Spun Out.
Yeah, so I can't praise Spun Out enough. I've always loved to write, and it was around COVID when I kind of started collaborating with Spun Out, because I had just come out of hospital for my mental health, and it was an opportunity to have something to do and have some sort of feeling of purpose, because it's hard as a young person to kind of have your voice heard. So that's why Spun Out is amazing, that it gives the opportunity to young people. I find it's most helpful because it allows young people to share their stories. They're not just providing information, they're giving real life stories that are easy to relate to. And they also, while they provide information, they also provide a service called Text About It, which is relatively new. It's a service where they have volunteers, and it's pretty what it says in the name, Text About It. If you have a problem, you can anonymously send a text and you'll get a reply from somebody who you can talk to, which is really helpful. I haven't used the service, but it's really helpful to know it's there, because people like me, I'm autistic and I hate phone calls. So having that service there that I can text about it is really helpful.
That's such an interesting point, and it links in with, like, you know, if people want to access services in another language, or if people use Irish Sign Language and they want to access services. So it's really about having an array of access, isn't it? So that people aren't, you know, like that. So you that suits you. You like the idea of texting about it.
Because
and then
even, sorry, I didn't mean to interrupt you.
No, go ahead.
Even the autism diagnosis, that does have a big role to play in my mental health journey. It was another big challenge in trying to find support as a young person, because a lot of services wouldn't take me on because of the ASD diagnosis, autism spectrum disorder. So I was getting help specifically for autism, so occupational therapy and things like that. But because of that diagnosis, it kind of was a barrier to services that would help with my mental health.
So if there were three things that you could change, I know we often ask about, like, you know, a magic wand and if we could change something overnight, but if there was kind of a long-standing three things in the mental health system and sector that you could change, that you think would make a difference, what might they be?
So I think,
children and young people, sorry.
Yeah.
Yeah.
So I think the biggest issue is there's not enough options available. So you could be on a waiting list for months, years, and then once you finally get that help, it might be with someone who you find out doesn't match your needs. But it's kind of like, tough, you've waited this long, this is the person available. So I think in an ideal world, I think funding should really go towards that, because we're kind of getting the bare minimum here. So obviously, magic wand, that would be great. And also a transition service. I know that they are being developed between ages of 18 to 25, but like I said, when I was transitioning, it was like being thrown in the deep end. There was no smooth way to go about it. I think that it should be essential for any young person attending mental health services to be given that assistance with transitioning to adult services. And lastly, it's been mentioned a lot so far, early intervention. It's so important. I think as well, a lot of young people aren't taken so seriously. So I think if they were to be taken more seriously before it got to the point of crisis, I think that, like you said, if you invest to save. So I think young people start their journey, if they start their journey in youth services and it's a bad experience, that's going to shape their view on getting help in the future. So early intervention is, a big one.
And I'm just wondering if you could, you said you're 26 now, like if you could say something to, younger Rebecca when you were trying to access services, is there any kind of piece of advice that would also, assist people listening in today who are trying to access services? Is there anything that you'd like
to say? Don't give up trying to find that right service. So like the way I was saying, it is hard when you're not given that many options, so it might not meet your needs. But I do think that hopefully in time to come, there will be that option available, and to make it easier to keep searching and not to give up because you're not receiving the help that you feel like you need. So yeah, definitely just don't give up the search for help.
And I think that's why we, in mental health reform, we put such an emphasis, I know I've said this a couple of times now, on sharing the vision, because there really are, as you said, Rebecca, like there is work being done on the, the 18 to 25-year-old, and so that people aren't just kind of, falling off a cliff when they leave, or falling off, not able to access services when they leave CAMHS, that kind of, been lost in the system and the supports. So there are bits and pieces of work happening, but it needs to be resourced. And
that's the main thing, that to acknowledge that there is a lot of progress from when I was transitioning from youth to adult services. There is so much progress, you can't deny that, obviously. But I think funding needs to be given to accelerate that, and to make it more available to more people.
Yeah, and I think there's such a good opportunity at the moment with the restructure that's happening from the 9 community health organisations into the 6 HSE health regions. So in everyone's regions around the country, there's now 6 regional executive officers, and we've sent copies of our pre-budget submission to them, and we're really hoping that they're going to engage with us. But it's a political priority. So it's political, and it's also the HSE, it's their responsibility to say, yes, we're investing in mental health. We're putting our own commitments, we're going to work towards the commitment of 10% of the overall health budget, which was supposed to have happened by 2024. Rebecca, thank you so much for your time. I think just someone was asking there, I saw in the Q&A, about links to places that were some of the organisations and groups that we're talking about. So obviously, if you go on to mentalhealthreform.ie, that's where you'll see links to all of our membership, and some of our work that we've done. Spun Out is spunout.ie, am I right?
Yes.
Yeah, and you'll be able to find Rebecca's blog there as well. So I'm going to hand back over to Fiona, our CEO, to wrap up for the last couple of minutes. We promised we'd keep us to an hour. So thank you so much, Rebecca, and I'll see you very soon.
Thanks so much.
Thanks, Rebecca. Thanks, Byrne, and thanks to our other panelists as well, Michelle and Sean and Naomi. I think you'll all agree it's really been such an insightful morning's discussion. I'd like to thank all their panelists for giving up their time, but also for their honest reflections on where things are and where we need to go. And I think, you know, it's really great. I suppose one of the strengths that we have as a sector is that, you know, there isn't perhaps enough resources, and people there's so many challenges out there. But I think anyone who is working both within the system or with the system, you know, everyone is really committed to really improving things, and I think that's really important. Yeah, so thank you to all the speakers who were there. I'm really struck by some of the comments that are coming through on the Q&A as well, around, you know, what can we do and how can we move this issue forward. And I think it's really clear, probably for the majority who are on this call, you know, over 130 individuals, that, you know, we're all committed to mental health and reforming our mental health services and supports, ensuring that there is better, more equitable access for those who need it across the country. And it's great that there are so many of us now, but I often am reminded as well that when we do have these events, we're very often talking to people who understand what we're saying already. So, you know, to individuals who have that experience and who are willing to step up. And we need to, I suppose, broaden our net and to get others involved. And as part of their I'm a Reason pre-budget campaign, I have an ask for everyone on this call today, and that ask is we want to make as much noise in TD's inboxes as possible to make them see that mental health is an election issue now, because for decades, you know, mental health has been surrounded by that silence, by that shame. People were not raising it with their election candidates when they came to the doorstep. So really would urge you, please share our Uplift campaign. You can see it if you go onto our website, mentalhealthreform.ie. It'll also be linked on and pinned on some of our social media sites. But we want to make as much noise as possible, and we can't do that without your support. So, you know, if everyone on this call committed today to get 10 individuals to sign up to the Uplift and then spread it on further, we'd really start making that ripple effect, because it is only by standing up and really showing that mental health is a priority issue. We have, you know, our own minister as well. I think, you know, she's really kind of aligned in terms of the need for more funding and more investment, but she's part of a broader cabinet, and every cabinet, or she's not even at cabinet, the senior minister at cabinet, but she's part of a broader government, where everyone will be out looking for money for their issue, for their department. And I think we need to make everyone in government, in particular those who sit around the cabinet table, aware of how important mental health is. So yeah, that's the ask for today, is to really go and to urge you to make everyone aware, especially our policy makers and those who will be taking budget decisions, that mental health is a priority, that investment in mental health just simply can't wait. There are too many reasons and there are too many individuals waiting for services and supports. And I really believe that, there's been so much passion and energy on this call today. And I think if we really continue to work together, we'll be able to continue to drive this movement that will create meaningful change. So a big thank you for everyone for joining today. Our pre-budget submission is available on our website for those who would like to read it. And a huge thank you to the Mental Health Reform team who've put today together. Really looking forward to rolling out this campaign over the coming weeks. So yeah, big thank you to you all, and please join us in making mental health matter and ensuring that it'll get the resources it deserves in Budget 2025. Thank you, everyone.
Thanks, everyone. Bye-bye.